Okay, so welcome, ladies and gentlemen, to this lunchtime session sponsored by Siemens and Trimencio. Thanks for coming, and bon appetit, everybody who's having a nibble. My name is Darren Mylotte. I'm an interventional cardiologist from Galway, and I'm joined by a stellar team of world-famous interventional cardiologists, Erik Nielsen-Kudsk, Martin Swaans and Lars Sondergaard, who are going to take you through this session, which is entitled State-of-the-Art Imaging for Structural Heart Disease Interventions. So the idea of this session is really to focus on the imaging and to understand what imaging gives us and what has changed in the last number of years. The specific learning objectives are to learn about the state-of-the-art imaging for structural heart interventions, to learn how to perform pre-procedural imaging planning, and to learn how advanced imaging can facilitate our procedures and make them easier and make them safer. Erik, in terms of our interaction today?
Yeah, thank you, Darren, and welcome. We want this session to be interactive, so you can interrupt us, you can ask questions. You can also use the chat, and there's also a virtual transmission here of this session, so people outside the auditorium can pose us questions through the chat. But we'll start, and we have two patients to treat for today. So we have one LAA patient, one AF patient coming in here for treatment, and we have later on a severe aortic stenosis patients coming in here. So let's start out here and look at our first patient today here. So this gentleman is 77 years old, AF, hypertension, moderate aortic stenosis, and a clinical presentation with intracranial hemorrhage while being on oral anticoagulation treatment, and with a very high risk of ischemic stroke and a very high risk of bleeding and also a risk of recurrent ICH. So he's a really good candidate for left atrial appendage closure. Looking at his transthoracic echo, he has a severely dilated LA, he has a moderate valve stenosis, good left ventricular function, okay renal function, and normal hemoglobin count. So we are going to do LAA closure for this patient. So how many here would take this patient directly now to the cath lab, go for TE on the table, and implant the device? Is that the way you would follow? That's one option. The other option is to do some more pre-planning before you refer to the cath lab. Any opinions here? How many would go directly to the cath lab without considering pre-planning?
So maybe another way, hands up who is doing a CT scan before all of your LAA closures? And how many people are not performing a CT scan before your LAA closures?
Yeah.
Okay, so there's only maybe half the audience would be routinely doing LAA closures.
Yeah. So okay. Martin, what will you do in your center? Would you spend time on doing pre-planning?
Absolutely. I think for a long time we had the issue in the Netherlands that we do not have reimbursement, so we try to keep it as lean as possible to save some costs, but and we only did a TE up front, not on the cath lab, but also up front. And why? Because you just simply want to know advance what you're going to look at. What is the morphology? Is there a thrombus? And I think now we move forward, and we do definitely see also the beneficial of doing a CT up front. So it gives you a lot of information. You can plan your procedure. You can see the anatomy of the left atrial appendage, and I think it helps to understand what you're looking at, and already helps you to decide what kind of device you're going to use, where you're going to implant it, and I think especially also with simulations nowadays, things are going to help us to optimize the procedure up front. So I think imaging is really crucial.
Good. And Darren, you would take this patient directly to the table, or?
So let me tell you a little bit about the situation in Ireland. So we have reimbursement, that's not an issue, but we don't have easy access to general anesthesia. So what often happens for us is that you do a TOE because you want to assess the patient, have they got thrombus, but then you can't actually treat the patient for 3 months, 4 months, 6 months. And so by that point, well, the assessment of thrombus, you need to repeat the TOE. And so we've tried to start moving our program towards using intracardiac echo and doing the device implantation without general anesthesia. So because of that, we've started using CT, and really we find that it's helped us tremendously in terms of understanding the anatomy that you're going into.
Thank you. And this patient here, our gentleman with ICH, he was admitted to the Heart Center in Copenhagen, and let's see what they decided to do. So they took him for pre-planning and did a cardiac CT scan. And you could just take your crude CT data and analyze them yourself, but we have a lot of dedicated software packages on the market, and one of them is this Remensio software, where you can just, by hitting one button on the computer, you can get a nice three-dimensional construction like this. And what you can see here is that there are put in two rings, a green one and a red one, marking the landing zone for a device and a disc position. So they obviously intend in this case to put in a double component device with a distal anchoring component and then a disc that covers the orifice. When I look at this three-dimensional reconstruction, I think I can be suspicious about a filling defect in the peripheral part of the LAA. I don't think we see the entire LAA actually on those images. And so Lars, how could you, are you sure that you're not looking at an appendage here with a thrombus?
Yeah, Jens, I don't think you can rule it out from this part of the CT scan, but there's more images on the CT scan, so you can go down and have slides and see where you actually have contrast all the way out, and also to see whether, if you can have some movement, whether it's actually a fixed filling defect or not. So I think for most of the patient, we can certainly on a CT scan, if you have high quality CT scan with good contrast filling, rule out there's any thrombus in the left atrial appendage.
Lars, can I ask you a question about the protocol? Because when we ask for a CT of the LAA, we get a CT coronary angio or we get a CT TAVI. Is there anything else that we need to be asking our radiologists or our radiographers to do with the scan protocol, specifically to rule out thrombus?
No, I mean, again, it's all the normal thing. If you have a high quality CT scan, you need to have contrast filling at the right cardiac at the right time. You need to be in the left side of the heart, of course. You need to have advoy patient motion, and you need to have high resolution. So often what we do is using this the same protocol as we use for patient with aortic stenosis going for TAVI. It's ECG gated. It's got sub 1 millimeter slide thickness and timing of the contrast, and I think that is going to give you really nice images.
Yeah. The timing is the issue, right? Some delayed phase imaging. Yeah. Martin, do you want to?
Yeah, no, that's really important. I think because of the patients in atrial fibrillation, flow velocities in the left atrial appendage are quite low. So having defects or not the LA completely filling at the early phase, it's something you quite early frequently see. So if you do a delayed phase acquisition as well, that's helping, because then there's a higher chance there is complete filling of the LAA. And if you don't do that, there will always be a discussion if there is a thrombus, yes or no. Yeah.
What does delayed phase mean? I'm not a radiologist. What does that mean? You scan, a few seconds later or a minute later or what?
I think you made a very nice paper about this.
Yeah, I don't know. Can you bring up an image here from the smart screen so we see it on the big screen? Is that possible? Or maybe you can see the small screen here. But as alluded to, in a lot of cases you see slow flow in the left atrial appendage. I mean, that's part of the whole concept of having the thrombus formed and the risk of thrombus formation. So it can be difficult to discriminate between slow flow and real thrombus. And what we can do is to do a delayed scan, and that will say typically 3 seconds or 10 seconds later. So you image the left atrial appendage in another phase of the cardiac cycle. And as you see here on the upper images, here you have a filling defect, and with a delayed scan you see that the LAA clears up. So that's a very good strategy to discriminate slow flow from definite thrombus. There are a few cases where you will still be in doubt, and then you might proceed in rare cases also to do a TOE to be completely sure that there's no thrombus. But let's see more here, because one thing that CT allows you to do is to do a very precise measurement. And you can see where you had the two rings before, the landing zone and the orifice. You can be sure with CT that you are absolutely perpendicular to the landing zone and at the right level of the ostium. And you can measure out the minimum, the maximum diameter, even the area and the perimeter-derived diameters for this appendage. So you can really be very precise in your device sizing with cardiac CT. One of the nice features are that you can also play with your projections from the CT scan and make sure that you plan a good C-arm position. And in this case, you can see having a 30-degree RAO, a 5 cranial projection. The red circle here, you see directly from the side onto where the disc is going to land. So this is a good alignment you can plan on beforehand. You can also consider the optimal site for the transeptal puncture. Looking at the right image, you have a RAO projection, and you can see that with the trementio you can mark out the superior vena cava, the inferior vena cava, and also the oval fossa. And on the right, if you are on the right in the oval fossa, you are anterior, and to the left you are posterior. And in that way you can see what will give you a good coaxial alignment of the sheet direction with the axis of the appendage. And in the same way, on the left image you have a LAO projection, and there you can identify the inferior portion and the superior portion of the oval fossa. In the vast majority of cases, we go for inferior posterior puncture to get good alignment towards the LAA, but in a few cases, like a reverse chicken wing, you have to be more mid to get a good alignment. So that's something you can predict from the CT scan. So here in Copenhagen, based on those pre-procedural images, they actually planned to do this procedure as Darren in his lab in local anesthesia guided by intracardiac echo. And this is with an advanced 4-dimensional ICE probe. And what is also nice from cardiac CT is that you can use fusion between CT and your angio projections, as we will see later on in the case. One thing that is also an option with those dedicated software packages is to do virtual simulation of the devices. And this is not the actual case, but an example of a double component device, a disk-based device, where you can predict how it will sit and look closer on this. And that's a new feature of the Trementio software package. But in a minute we are going to proceed with the case itself. But Martin, we need also consideration. Is it okay to go on in this case with an ICE probe and a 3D ICE probe, or what would you do? What is your favorite intra-procedural imaging strategy?
It's for in the Netherlands, like I said, I think there are several ways to treat these patients. You have to decide per center what do you have access to and what do you like. I think there's still quite centers that have easy access to anesthesia. They will probably go for 3D TE. But a lot of centers have problems with getting anesthesia. And there are two ways I think they can go. They use smaller probes, so to get away of anesthesia by using the smaller probes. Or they move forward towards ICE, and then frequently, because you want 3D imaging up front, they will do a CT to give you all the details up front. So, and I think it doesn't really matter which way you like it, either way. So, but I think it's necessary. And the nice things about these new technologies and the fusion, you can take all the information you already got from the pre-procedural planning also into the procedure itself and use it during the procedure.
Jens Erik, can I ask you a question? In fact, two questions. The first is, can you tell me the things that you get from the CT so that you go into your procedure knowing what are those things?
Yeah.
And the second question is, how do we size? Do we size, you showed us there, the area derived diameter, the perimeter derived diameter, the mean diameter, and can it change in terms of the patient's volume status? What do you do in terms of loading the patient with fluid, either at the CT time or at the procedure time?
Yeah. Great questions, Darren. I've put up a slide here on the smart screen because that is from a consensus paper we did 2 years ago. So if you are not familiar with pre-planning by cardiac CT, you can see what is the optimal protocol and what can you get from this. This is a good technology to rule out thrombus, as we already have alluded to. Use always a delayed scan so you can discriminate slow flow from thrombus. You have already seen that you are also able to actually plan the puncture site in the oval fossa to get the best alignment towards the LAA. You can also very nicely look at some of the surrounding structures. One of the markers that we have is the circumflex artery. We use the upper pulmonary vein and the mitral valve. You can see the relationship also to the pulmonary artery. So you can see all the adjacent structures, which is also quite nice in your planning. But device sizing is something that you really can derive. And if you have a disc-based device and measure out the maximal diameter of the orifice, that is a relevant parameter because you want your disc to cover the full orifice. So the maximal diameter is a relevant diameter for the disc. If you go to the anchoring part of your LAA device, it's different between the different devices. If you, for instance, take the flex device, when you compress the flex device, it stays in a circular shape. So for the flex device, you need still also for the landing zone to measure out the maximal diameter. If you have other devices that are more conformable to the anatomy, you would take more the mean diameter, maybe even the perimeter diameter. So it is device specific, and I think also that the device companies need also upgrading of some of the sizing recommendations based on CT, because as it is now, most of them are based on actually TOE.
Okay. Jens Erik, just as you're about to press play on the video and we see how Lars and the team executed this case, Lars, I see that you're going to implant the Omega device. Can you tell us, for this particular patient, why did you choose that device?
Yeah, I think this patient could probably be treated with most commercially available devices. So this was by coincidence we choose the Omega device. I mean, it's a favorable anatomy both for the Mylotte device, for the Watchman device, or for the Omega device as we are going to use here.
So let's look at our gentleman here and the team from Copenhagen, how they do it.
You, Nielsen, you explain what you actually see on eyes while Ole is coming down here with the sheet from the SVC towards the fossa ovale.
I see the needle now coming down.
I'm coming slowly down. I have it at 5 o'clock, both elements, both the flush port and the needle arrow. And soon it will make a drop. I think it maybe probably already made some kind of drop.
Now I see the tenting, yeah.
But we're still maybe on the highish end.
Yeah.
I can come a little bit we can nicely appreciate this on the eyes, so I come a little bit lower.
Then you swap to the other view, so we are sure that we are...
The aorta anterior.
You see the aorta here on the right-hand side.
Yeah, on... no, do fine. Now it's fine. It's in the posterior part.
Which is on the left-hand side of this
So I'll give it a
image.
bit more gain.
Yeah.
So I'm coming out with a needle here. Yeah. You still see nicely the tenting?
Yeah, you're tenting.
Yeah, okay.
So we can just cut it from here.
Yeah, it went through.
Yeah, you're through.
Yeah, so now what we're going to aim for is to have a rail up to the left upper pulmonary vein. We want to establish that. And with that rail, we will place in a stiff wire and we will introduce our delivery system and then pre-dilate the fossa ovalis. And after that, let's pull it back a little bit. Yeah, let's see if we get there. Yeah, that's beautiful. Yeah.
So that's a standard multi-purpose catheter.
Yeah.
And we can introduce a stiff guide wire, which is going to be a super stiff Amplatz guide wire.
So this is that rail we're going to introduce, an unplug super stiff. It's going to sit in the left upper pulmonary vein. And after that, we have a nice rail to bring up our delivery sheet. Okay. Good. So now the sheet is slowly coming up. That's good. So now you will see somebody holds the wire. Good. Yeah. I will go a little bit further.
So what you do now is always you're crossing the septum with the sheet and using as a dilator.
Exactly.
And then bring the sheet back into the IVC, and now Niels will try to advance the ice catheter across the same holes in the intra-atrial septum.
Yeah.
So for LAA, you get imminent images if you advance the ice catheter to the left atrium and do the imaging directly from there.
Ice images itself, but also on fluoroscopy, the guide wire as a landmark easily past the ice probe from the right atrium to the left atrium, and now we can re-advance the delivery sheet across the septum once again. So Ole, just tell us what you did here and what you actually can see on the screen.
Yeah, so we can choose ourselves what we want as an overlay, as a fusion imaging. So what we chose here is to keep it very simple. So we have on the left-hand side, that circle is the fossa ovalis, and that's very nicely indicated because that's exactly where the eyes and our delivery sheet of the LA closure device, of course, cross. So that's the fossa ovalis. And then, of course, in the LA, we have the ostium, we have the landing zone, indicated by the two circles, and then the central line of the LA, which we amputated. We don't let it go all the way in, but that gives a nice illustration of where we have this appendage and where we want to land with the device.
Yeah. So what you actually did here is you fused the CT scan we had pre-procedural with your actual fluoroscopy.
Yeah, exactly.
Okay.
Yeah. And this is now live, and indeed I'm going to counterclock with my delivery system. Yeah. I even have to talk a little bit more, I think. Yeah, like this. Yeah, and we're in. Yeah, we're in the appendage.
Very beautiful.
And you see we almost fall together with that central line of that LA, so that also shows that our delivery system is nicely aligned into it.
Yeah.
The view we have is a 45-degree view with the aorta seen in the image, and we have the Coumadin ridge up here. And in this area, we have the left atrial, the circumflex. This is the pigtail going into the left atrial appendage, and now that it's 4D ice, we can also demonstrate that on the 4D image, where we see the catheter going into the appendage.
Running to running connection. Yeah, that's good. Okay, and then we slowly will push the device forward.
So we can see here both on fluoroscopy, on ice, when the device in a second here will come forward. Let's see now, we see the most distal part, the cup, as you saw before, is now approaching the end of the tip of the sheet here. So if you go back to the fusion imaging, if you can see that once again, full screen. Yeah?
Yeah, this is live.
And I'll push a little bit out, or you tell me when you want to start to...
This is still fine. You see that the end of the delivery sheet is just falling together with the landing zone. I think this is perfect. So I want to keep it there. Yeah, this is.
And we want to create this.
Yeah, and go a little bit counterclock, and now push it a tiny bit forward. Yeah. Okay.
And this is
push a little bit out with the device still. Yeah. We continue. Yes, it's nice and well controlled. Yes. I like this very much.
Can you make a little bit more like this?
Yeah, like this. Perfect. That's really perfect. I think. Okay, so the cup is formed.
Yeah, and we now come back with the sheet in order to create the disc.
So that you do, Lars, so you keep the device in place and you unsheet kind of this disc, yes. And we have at the same time a good tuck here. Now we push the device, the cable a little bit forward.
And now,
beautiful. And also on fusion, it's actually beautiful demonstration, I think. So live, I will go to live image.
And you see also just seeing the fusion, just you see that you have the cup just at the landing zone, you have the disc just at the ostium. So let's go back again to ice and see what Niels can tell us. If you see ice full screen.
It's really nice because it seems to be covering just the Coumadin ridge. The pulmonary vein is coming in here, and here you see the ridge. The disc is going up here. We saw the disc, the cup being formed nicely inside the appendage. And here we see the mitral valve and the circumflex. And I'd say this is a very nice position.
Well, we can do a chuck test. So I pull back on the cable, bring the disc a little bit away. We can keep it here for a few seconds and see where the cup is in a stable position.
Yeah, so this is a good duct test indeed, and then I think this is indeed sufficient.
Push it a little bit back again.
Then we can go back to the fusion imaging once more. And then you see that it didn't move. So that cup sits still. I would say it has to be 2/3, and it sits completely distal of that landing zone ring. And then our disc indeed falls very nice together with the anatomical ostium. We haven't actually given any contrast so far now, so that's the luxury with the fusion.
So I'll just do some counterclockwise rotation here on the cable and wait for it to come off. It's already off, yeah?
Yeah, it's off. Yeah.
Okay.
I think it's an LA closure. I mean, we know that it's not always easy. The anatomies are very variable between patients, but having this optimal imaging, both pre-procedurally, but also during a procedure, intra-procedural, with the eyes, with the 40 eyes, and with the fusion imaging, it makes it just easier. It lets you know where you are exactly all the time. And as we demonstrated, we could do this in procedure without any contrast injection, so that's also an advantage.
Thank you, and Lars, that was a great case, and it was a really good demonstration of this fusion possibility that we have when we do pre-procedural imaging. And I liked you had just the essential structures here: the oval fossa, the disc position, and the landing zone. But could you tell us about the limitations using fusion?
I mean, first of all, I would say that moving to using this CT scan as pre-procedural is very logical. For people who's doing a TAVI procedure, I think no one today would do a TAVI procedure without having a CT scan for very accurate workup. And you can see here it offers you a lot of information here during your planning the procedure, and with the fusion imaging as well to overlap it in the cath lab. A case done with zero contrast. I think that's certainly the way we should try to move forward. The limitation is, of course, that when you look at the fluoroscopy, it's going to be dynamic. It's going to change according to the heart rhythm and to the patient's respiration, whereas the CT scan will be, fixed on the table. And of course, also you need to have an idea that the patient is positioned on the table in the same way during the procedure as he was in the CT scan. So that he cannot be rotated to one side and the other. But again, as you saw here, we don't need to have it exactly on the millimeter. It gave us very nice guidance despite that.
So Lars, most of us who do these procedures, we're all used to going ariocaudal, ariocranial, let's take a picture, let's take another picture, which view is best. All of that hassle seems to have been taken out of the procedure by the pre-procedural planning.
Exactly, because you know from the CT scan exactly where to position your C-arm in order to be perpendicular to where you want to see it, to elongate your landing zone.
Yeah. One technical point that I'm sure people appreciated was that you seem to electrify the transeptal needle to puncture. Is that something you do always, and can you tell us how you achieve that?
Yeah, it's actually just a Bowie, as the surgeons are using for cutting or coagulation, so we always have that. So when the needle is against the septum, just apply RF energy for a second or two and you'll go through. I think the advantage is that it's not going to slide the needle as you push on it, so you have a more accurate puncture site.
You also demonstrated the use of a 4D ice probe, so you have also been using 2D ice probes. Do you think that this provides you with some advantages for LAAC?
I think there's some advantage with it. Of course, since you have the CT scan up front, you have all your measurements before you go into the procedure. So you don't need to have the same way of accuracy. But I think it's nice to guide the procedure as well. And also it may, even though we're still in a kind of a learning phase, give us a better assessment of peer-device leak, which can be a little bit limited with the 2D probe. But I don't know whether you can comment on that, Martin.
No, I agree. I think with the eyes, it's frequently difficult to completely do a full sweep, which we can do with the TE probe around the device. And now by simply having a 3D modality looking en face on the device, of course, you can easily see how the device is landed in the LA, but also the peri-device leak is much easier to see in an en face phase. So I think it will be definitely beneficial to move to its way.
And I think in the same phase as TAVI, whereby initially a TAVI procedure was successful if the patient was off the table alive with one valve, I think we need to move on from the patient has a left atrial appendage device in and they're okay. We need to be thinking about device leaks. We need to be thinking about erosions and so forth. Jens Erik, one more question for you specifically before we move forward. The thing that I struggled with when I moved to using ICE guidance was that, of course, we get we get superior and inferior from our ICE probe. We don't really get anterior, posterior, and you said it's quite crucial to have a posterior inferior puncture. Can you tell us how do you assess anterior, posterior with a 2D ICE probe, which is what most people have?
Yeah, I agree, and it's something that people struggle with, but it's very easy to do that because you just come with your ICE probe to the right atrium without any rotation of the tip. Then you seek the home view and you posterior flex the tip of the catheter a little bit so you have a good superior, inferior view of the septum. The septal view, that is very easy to get. And from there, if you rotate clockwise, you will look upon the posterior part of the septum, and if you counterclock rotate on the shaft of the ICE catheter, you will look towards the aorta, towards the anterior part. So that's the way we do it. It might be even more precise when we have the three-dimensional probes, where we like a TE probe can exchange or switch between the imaging planes or even do X-plane imaging. But we have another Darren patient to treat today, so let's proceed.
We should switch to something a lot more fun.
Excuse me, can I have a question?
Please do, come to the mic. And again, anyone has a question, hands up, come to the mic. We want to hear from you.
Thank you so much. Concerning the fact that this session is imaging for structural heart disease, and you show the CT scan imaging, so as all of we know, these images should be gated, EKG gated, and the patient has generally with the structural heart disease AF, and this is some problem in getting low with the AF rate to get the best picture as we can decide about the LA auricle or even in TAVI cases. What is the lowest limit which is accepted for doing this procedure? And a question that the moderator asked, what do you mean by late image? How late is this should be to get a good definition of thrombus there?
Thank you for the questions. The last question, our delayed imaging is just 3 seconds after our first acquisition, and we are using a flash protocol, so we are only having an image in a very specific part of the cycle, and normally we go about 40% into the RR interval. And we never use beta blockers or anything. Even though you have a patient in AF with a flash protocol, you will get quite sharp images, so it's not an issue. Actually, having a patient in sinus rhythm can be a challenge because you want to capture, if you go for a flash scan, you want to capture the heart where the filling of the LAA is largest. And there's a variation here. We will take an average of going about 30 to 40% into the RR interval, but we have to keep in mind that we might capture the LAA in a little bit contracted state, so we can, in theory, run a risk of underestimation. And one of our routines is actually still to do the selective LAA angio and check the measurement also on angio, and we also look at ICE to be sure that there are agreement between the different imaging modalities we are using.
Most of us don't have flash imaging. These guys are from a very wealthy country with a pretty good football team who keep beating the Irish, unfortunately. But we tend to use, it's a retrospective gating, and we take from 10 to 90% of the cardiac cycle. And you're right, with atrial fibrillation sometimes, or even the patient moves or breathes, you can get some artifact. And the way to deal with that is that in one of those 10 phases, you're likely to get a phase that looks reasonable. But of course, take also when you're sizing, take the largest of those images rather than the smallest. Okay, so we're going to move forward with TAVI, but again, if you have questions, use the app or come to the microphones. And this was a patient, again, that Lars and his team treated in Copenhagen. So a 75-year-old female of small body mass, paroxysmal atrial fibrillation. And so you'll see the quality of the images here are not affected by that. The patient has a pre-existing pacemaker for AV block. Young, relatively speaking, and low-risk patient. And the patient was symptomatic with severe aortic stenosis. To demonstrate that, the mean gradient across the aortic valve was 40 with an aortic valve area of 0.9 and preserved LV function. The ECG demonstrated atrial pacing, so probably paroxysmal AFib. The angiogram, which is interesting, Lars, to discuss whether or not you still do that, does not show obstructive disease. And in this patient, hemoglobin a little below normal for a female and a GFR of 50. So Lars, maybe before we get to those images that we're going to discuss, are you still doing invasive coronary angiograms, given that this is a non-invasive structural session?
Yeah, so we do that even though there's been a constant discussion about skipping it. Start looking at the CT scan, because it's actually a coronary CT scan you get, so you can rule out whether the patient have any coronary artery disease. And if you do that, it may be half of the patients, which maybe even more of the patients, who don't need to have an invasive assessment for coronary artery disease. So it's certainly also an information you get from your CT scan. You can streamline your procedures, save contrast and save resources, not doing an invasive assessment of the coronaries.
Yeah. So of course the TAVI population are older. They tend to have a lot of calcium on board. Again, you can get movement artifact. But it's about 60% of patients that if you do the CT TAVI first, you can rule out significant calcific proximal coronary artery disease, which is the whole point of the coronary angiogram in the first place. So many centers have moved away from doing that invasive angiogram. So one of the big advantages, again, of pre-procedural planning.
And maybe good to mention, Darren, that we actually recently published a paper even with CT FFR, and that seems to increase even the number of people need to be referred to the cardiac cath lab.
Excellent, excellent. I forgot to read Jack last week, Martin, but thanks for reminding me. So, of course, pre-procedural planning for TAVI really has been refined and developed in the last 10 years. Certainly, at the start of my career, we did a two-dimensional TOE sizing. We did an aortogram during the case to try and find the optimal implant angle, and many of the complications that we had during early TAVI procedures were due to bad decisions that we made from that planning information. And so the CT scan from any of the vendors and indeed the assessment of that raw data is crucial. Tremensio are one of the systems that provide that. They provide a very easy workflow. It's semi-automated system and gives you images and information like this. So this particular patient has an annulus perimeter of 74.7 or an area of 432. There's a little bit of calcium that you can see there. I think it's always very interesting to know where the calcium is. Is it on the right or is it on the left? In this, it's in the non-coronary cusp at the base of the sinus. Important that the LVOT is approximately the same diameter. It's not dramatically smaller in this patient. The patient has large sinuses of 30, 29, and 28 with no very severe calcification on the leaflets seen in this particular image. But there is some calcium at the sinotubular junction with an average diameter there of 24.9. And that's very important when you're trying to consider your pre- and post-dilatation balloons. The coronary heights, the right is 18, the left is 14.7. So generous sinuses and high coronary heights really suggest that the risk of coronary occlusion in this patient is quite low. And we don't see extensive calcium running down in these images down into the LVOT. Pre-procedural understanding of where that calcium is and indeed quantification, which on the newer update from Tremensio is now automated. In this case, we see moderate leaflet calcification with a small amount of annular calcification. And so a good anatomy for most transcatheter heart valve devices. One of the things I think that we forget very often when we're imaging for TAVI is to look at the aorta, not just the arch as in this image, but also look at the descending aorta, because you can have surprises there that could alter either your decision to do a TAVI in the first place or indeed the type of valve that you would choose. In this particular image, they've shown us the 3D reconstruction, showing us the arch, showing us the calcification pattern on that arch, and at the same time being able to measure the diameters of the innominate and the left carotid artery to see is this patient suitable for an embolic protection device. You've all seen these images before. Again, beautiful images that tell us a huge amount of information in terms of where's the calcium, how much tortuosity is there calcium at the level of the tortuosity, and indeed at the puncture point, the bifurcation, where is that? You can see on the right side it's a little bit higher, it's a little bit lower on the left. So although these images are sometimes construed as being irrelevant and not relevant to in terms of the size of the arteries or the diameter of the arteries, these are actually crucially important for planning a safe and effective TAVI. So Lars, you assess this information. You decided to do this patient under local anesthesia, which I know is your standard practice, pre-closure, 14 French eye sleeve. You decided a sentinel embolic protection device was appropriate in this patient, and pre-dilatation with a balloon and treatment with the accurate Neo2 valve. As mentioned, I think this patient is probably suitable for most commercially available devices, but there are some advantages to the accurate, particularly in younger patients, such as Commisural alignment can be effectively done, and Martin's going to talk about that in a moment. That ensures coronary access into the future. We know that this valve has best-in-class pacemaker rates, with rates as low as 7-8% in an all-comers population. Great hemodynamics because it's a superannular valve, and we're recently understanding that this is a valve that can actually be revalved in due course with a low risk of coronary occlusion. To show you how this valve works, it has a top-down deployment rather than a bottom-up. You release the upper crowns, that captures the leaflets as you see. The stabilization arches at the top come down. These rest very often on the ascending aorta and give you a very smooth final and rapid deployment of the bottom portion of the valve. Martin, will we, before discussing Commisural alignment, maybe discuss a little bit the case and the images and what your thoughts are in terms of how you would treat this patient with that information?
I think, yeah, we've seen, I think, first of all, of course, is checking the femorals. So we see that the femorals are accessible. So there's quite some calcification, but it seems like the diameters are suitable for implantation. Of course, indeed, looking at the arch, what is the arch? Is there a lot of calcification there? Do we need a different approach for that? But as you can see here as well, you don't see a lot of calcification here. We're going to use a protection device, and afterwards we go to the measurements, and it all seems like all the measurements actually fit perfectly in the accurate Neo2 M valve. So okay. I think it should be.
Lars, in terms of your assessment, is there anything different that you do now that you didn't do in the past in terms of understanding calcium burdens, measurement of membranous septums, and so forth?
Yeah, now we didn't talk about the membranous septum here, but that's of course also an important information, because the longer it is, the deeper you can plant the valve without the risk of conduction subabnormality. But again, you saw we have already decided which size balloon. It's based on the CT scan, the minor axis of the aortic valve, what size valve should be implanted. We know that there's no risk of coronary occlusion. So I think we have all these things up front, which can also make a difference what kind of valve you're going to use. Let's say the patient had a lot of calcification in the left ventricular alpha tract with a risk of annulus rupture. Maybe it's not a good candidate for balloon expandable technology. So I think having this information is adding a lot, make it a lot more easy to plan your procedure, which device are you going to use, what strategy you're going to use.
Okay. Lars, one further question is that we're planning at this stage, particularly for younger patients like this, can we revalve this patient in due course? Because a 75-year-old might in due course, in 10 years or 15 years, might need a second valve. How does this imaging help us understand who might be a candidate for a TAV in due course?
Yeah. So the issue about doing a TAV in TAV is that you're going to create what we call a new skirt. You're going to push the leaflet aside. and that could potentially block the access to the coronary arteries, which of course is not acceptable. So seeing how wide the sinus of valve is, where's the coronary taking off, we know that if you're going to revalve this valve later on using a short stent frame like a Sapien valve, in this case, I would have no concern that we will be able to access the coronary arteries. Yeah. Martin, in a second, is going to talk about how to clock these devices, to have Commisural alignment, to even have easier access to the coronary arteries afterwards.
Okay. One of the other things that's, again, available on the newer version of Tremensio is that they have STL files that you can implant. So in this patient, you can implant an accurate Neo 26, 29. You can do the same thing with a Sapien or a core valve. And you can therefore see where does the frame of this valve sit, how much room do I have around the side of the sinuses and so forth. And so that's going to help us plan for the second procedure. One thing I also like when looking at these images and planning about the use of an embolic protection device, certainly in Ireland, a Sentinel device is €1,200, and one of the main difficulties with getting that device in is tortuosity up here in the subclavian and the brachiocephalic system. And all imaging softwares allow you to have a quick look at that and understand if that is a very tortuous anatomy. Perhaps that's a patient that you're gonna keep that system on the shelf and not use it for that particular patient. Mm-hmm. Martin, you want to take us through Commisural alignment with the Accurate Neo 2 device?
Absolutely. So, as already said, we have a quite old population at the moment, which 1 in 2 or maybe a little bit less, but has significant coronary artery disease as well. So there's a high chance that after the procedure we might want to go in and want to have access to the coronary arteries. And also 10% of the patients who get a TAVR get an acute coronary syndrome, so we need access to the coronaries. And also if we move to younger patients, we want to make sure that after the procedure we'll always be able to get there. So how are we going to do this with the Accurate Neo 2? I think what we're going to do is we use 2 views, actually. We use the three-cusp overlay, the coplanar overlay. I think everybody knows that, where we can see the markers normally. If we do not do the angulation measurement, we can see the markers over there. And we're going to use the right and left cusp overlay. And normally, we know already by using the Tremensio which angulation we're going to see this, so that's easy to use during the procedure. And first you're going to implant or introduce your valve, and you want to see the 3 stent posts. I'm going to show you here a little bit back. You want to see the 3 stent posts up in the free cusp coplanar view. And after that, because if you see your free post above the sinuses, it could be that you have a perfect alignment, but it could also be that you have a completely misalignment. So we need a different view to check if we're sure that we have a Commisural alignment. And for this, we're going to use the cusp overlap view, where we're going to have the non-coronary cusp over here, and we have a right and left cusp overview where we have the right and left Commisural over here. And now, if we go to the implantation, this is how it looks from above. So we can have an overlap, and there's one Commisural here. And this is how it looks during the implantation. But if we go to the prosthesis again, we're going to use the post, but also you can see above the Commisural, there is this free stent strut where we don't see, and that's what we're going to use. So if we go to this implantation view, we saw 3 posts in the free cusp coplanar view. We go to the cusp overlay, and we look at the post, and we look at the free stent. And what we want to see is that we see 2 posts on the left and 1 post on the right side, and the free stent strut here. And if we see this, we know that this valve is nicely aligned, and if we employ, we are not going to obstruct the coronaries itself. So nicely can be analyzed up front already with your Tremensio software, the angulation what you're going to do is, and if you're not optimal, you just have to rotate. I think it's crucial for these patients to do. And maybe one good question maybe to Lars, because we're talking about Commisural alignment, but of course not always all the coronaries come from the normal space in the coronary sinus. So sometimes it's not Commisural alignment, but people talking about coronary alignment. What do you think, Lars? What's more important?
If you're talking about access to the coronary arteries, we consider that the coronary arteries take off in the middle of the cusp. But we know, particularly for the right, often you have eccentricity. So the right will take off closer to the Commissures between the right and the non. And in those cases, you have to make a consideration. Should you try, instead of align your stent frame to the cusp, align it to the coronary arteries? It's about 3% of the patients with tricuspid valves. it's about 7% of the patient with bicuspid aortic valve. So you have on each CT scan to make a decision, which is the best implantation view, and of course you can also take into consideration what kind of right coronary arteries. Is it a small, non-dominant, maybe we should only focus on the left, or is it something you also should take into consideration? So one more feature you can actually get out of this from the CT scan.
Yeah, I think so. Any questions for now, or else?
So let's go ahead and see
Yeah, I
how
think
they
so.
how they
I will
treated this
start the case.
patient, yeah.
Yeah, we have one radial access, of course, for the sentinel, cerebral embolic protection.
6
and then
French?
6 French, yes. And then we have 2 arterial access, one for the TAVI site on the left, where the 2 profiles have been deployed now. And then we're soon going to introduce the eye sleeve. And then we have a 6 French for pigtail and a venous access for, well, we either for a temporary pacing wire or for this, we will explain later, for this temporary pacing on the small wire.
Mm-hmm.
Yeah.
And you saw we're going to use the sentinel device. We had the CT scan up front. We saw the anatomy of the neck vessel. So we're not going to use, as most sites will do, an aortic root injection to visualize the neck vessel. We're going to recall how it looked like on the CT scan, and having this AL1 catheter around the aortic arch, we also have a marker where is the outer curve of the aorta. So we don't need, for most of the time, we don't need any contrast here. These are the landmarks we need. The CT scan we did pre-procedurally, and this AL1 catheter in the aortic arch. And there will be 2 filters. One filter will sit in the innominate artery, the most proximal, and the distal filter will sit in the left common carotid artery. So 3 out of the 4 neck vessels are protected. The only vessel which is not protected is the left vertebral artery. So there's 3 steps. You see there's one slider here, there's a knob here, and there's a bottom here, number 3. 1, 2, 3. So as Ole or Gintas here is taking back slider number 1, you see that it's going to open for the proximal filter, which, as I said before, is going to sit in the innominate artery. Afterwards, Gintas will take knob number 2 here, and as he rotates that clockwise, you see that the catheter is going to flex, so it's pointing up to the arch. And again, recording how the anatomy was from the CT scan and also looking at this AL1 catheter, Gintas is advancing the wire up to the left common carotid artery. And with this position here, I think you have a nice position, I would guess, here.
Yeah. Can deploy the last one.
Gintas is taking knob number 3 here and pushing that forward. That's going to bring the distal filter out in the left common carotid artery. That's it. It's very easy to do it, and as you see here, you can do it without any contrast as long as you have your CT scan and a catheter in the arch to have as a landmark. So the nose cone and the valve is loaded here. This is just to introduce into the eye sleeve, and then we're going to pull it back. And then we have the system here. We can look at the handle in a minute. You see the flush port here is 6 o'clock. And that's corresponding to what you do with the envelope where you have it 3 o'clock. So 6 o'clock is a way to do it. You can also do 2 o'clock or 10 o'clock, but 6 o'clock is probably the most easy way to do it.
Okay.
Flush port and this safety tab is 6 o'clock. But that was the first thing. Doing that is going to give you a kind of near commisural alignment in most patients. But patients are different. The tortuosity of the access vessel, the aortic arch, the location of the aortic valve in the chest will be different from patient to patient. Some patient will not, this will not going to give you commisural alignment. So next step is, you see now, Ole is advancing the system just above the aortic annulus. Here, if you look at the, you see that radiopac dot in the middle of the stent. If you look just on the left-hand side, you see one stent post is there.
Yeah.
So we need to bring one of the 3 stent posts by itself on the right-hand side, again in a right-left crossboiler view. And you see it's actually pretty close to it. And also if you look at the post a little bit higher up, you see one is isolated on the right-hand side and the 2 other is overlapping on the left-hand side. So this is patient-specific commisural alignment. So it's not only depending on how you introduce your flush port, 6 o'clock, but you're going to do a fine-tuning in this right-left cusp overlap view. So I think if you're happy about that, Ole is now going to cross the valve. Again, you see that radiopac marker in the stent frame, that needs to be at the annulus level, at the bottom of the pigtail. We can just confirm on angiography that the pigtail is in a nice position. It is. So,
Yes.
so Gintas, you take the knob number one, and go counterclockwise slowly. That's going to, as I said before, do a top-down deployment. You're going to have, first you see now the upper crowns are open. Gintas is continuing, and now you see the stabilizing arches is coming out at the top of the stent frame. Okay? And we can confirm once again that we have a good position over with the radiopaque marker. It's just at the annulus level. So next, Gintas is going to pull out that safety pin. He's going to take knob number 2, still do counterclockwise rotation, but now just much faster.
Inject one more now. No, it's okay. No, I'm
So-
going. Yeah. Very good. Very good.
And you see here, now the info portion is coming out. So it's a top-down deployment, very easy. It's, even though it's a self-expanding technology, it's a little bit like a balloon expandable deployment with this very fast. So, and you can already see here, if you look at these posts at the upper part of the stent frame, you see one is isolated on the right-hand side, and the 2 other is overlapping on the left-hand side of the screen. So you know for this patient, you're going to have patient-specific commisural alignment. So now it's just, as always, to bring the system safely out of the LV without interfering with the stent frame into the descending aorta. And then Gintas is going to do exactly the opposite. He starts with knob number 2, now doing a clockwise rotation, and then going to knob number 1 and do again clockwise rotation, and you see that the system is going to close, and we can bring it out. We can do some hemodynamics here. I'm just going to do it. We had 53 before. We got 42 now. It's a bit lower diastolic pressure. We got 17 in the LV. That's in diastolic pressure. That's exactly the same.
Okay.
So now we're going to do an aortic root injection as a second assessment. And you see we are still in this right-left cospolar view. It got several advantages. First of all, you have no parallax on your stent valve, but also the valve is now on the right-hand side of the descending aorta. So the LV and the descending aorta will not be overlapping. So you're not going to be fooled about the contrast in the descending aorta. You're going to have a clear LV for the contrast. So let's do an injection here, Ole, and see what that tells us. Yeah, I don't see any PVL at all. I don't know what you guys are saying. So I mean, this new
nice.
2 with this extended sealing skirt really have made a big difference in the rate of PVL. So even in patients who have quite severe calcification, it's working really nice. We check. We normally don't check. Was anyone looking? You got it, yeah?
All right.
So you can. Yeah, that was quite a lot of debris. Can you zoom in here and film further in?
Or something.
I'm convinced sometimes that the companies give you guys little packets of stuff to put into the filter, so you can say, "Oh, look at this." I never see anything in my cases. Okay, so Lars, I think that we saw very clearly there, right, that the pre-procedural planning allowed us to execute a really simple, straightforward case, select the right valve for the patient, get commisural alignment, and get in and get out of the patient very safely. Questions from the floor about the procedure, about the imaging? Yeah.
Thank you so much. I have an utmost chance to have a training with Professor Sondergaard. And there is a pre-shaped formula for getting commisural alignment with Evolute R. It's to keep the flash point at 3. As I noticed in this view, for accurate, Neo is at 6. So when we get at 6, there will be commisural alignment in 90%, something like this, huh?
20%.
20%?
80% of the patients. 20% will still have severe commisural misalignment. Mm-hmm. And that's why when you have this CT information, you can actually adjust it. You can have this fine-tuning for each specific patient. Yeah. Everything told you on your pre-procedural tremendous workup.
So
Thank you.
with Evolute, by putting the flush port at 3, you're going to get Commisural alignment in 75% of cases at best, because it's not patient specific. You can't rotate an Evolute system, and if you can rotate it, you've no markers to tell you where the Commisural posts are. On the other hand, the Accurate, as you can see those little posts, and you can see those little barbs or free cells. And so if you know the anatomy from your CT, you can rotate it to the perfect position like we saw, and it takes approximately 40 to 90 seconds to do it. Okay, so I think that with that, I think we'll close the session. I want to say thank you to all of the speakers, to Jens Erik for sharing this session with me. I'd like to say thank you to the sponsors, to Tremensio and to Siemens Healthcare for helping us with the session, the technical staff, and indeed to all of you for coming along and sharing your cases with us. And finally, a thank you to Gabor Toth, who's online as the chat master. So thank you for coming and sharing your experience with us, and enjoy the rest of your day.